So when we were talking about faucial diphtheria, we need to first talk about the etiology. So etiology is that it is usually more predisposed to children, and adults are also not escaping from this disease. Although, well, it's caused by the so-called Corynebacterium diphtheria, which used to be that gram-positive bacteria with Chinese letter pattern, and like they used to have haphazard arrangement, and they used to have that. Uh, you know they were the typical bacteria, and after you catch the infection, like after 6 days, that's when you start getting the symptoms. So that is your incubation period, and usually it is caused by who are infected with Corynebacterium diphtheria and already having diphtheria, or some people who are carriers who are just having the bacteria within their throat. Then talking about the clinical features, you need to remember that this kind of infects the oropharynx, and it does not even spare the larynx and nasal cavity though. But tonsils are of course affected. That is what we are talking about, right? And sometimes it spreads to the soft palate, and it goes to the posterior pharyngeal wall, causes bleeding. This membrane which is called is very, which is caused is very tough, and it causes bleeding on removal. But more aggravation happens when it involves the cervical group of lymph nodes or the jugulo-digastric lymph nodes, and causes a bull neck appearance. And talking about the complications, this infects the heart and the nerves, causing myocarditis, cardiac arrhythmias, and the acute circulatory failure. And nerves, it could cause, like neurological deficits, causing the paralysis of the soft palate so badly that it could even infect the diaphragm and cause respiratory issues. At the same time, infect the ocular group of muscles, causing, discoordination or non-coordinated movements of the eye. Right. Talking about the treatment, it's an emergency condition. Like clearly, it's an emergency condition. You have to start treating the exotoxins, because that's the thing which is present in the blood, causing so much of damage. So you have to give antitoxins, and but before that, it is always necessary that we assess the severity of the disease and give the dose on the same basis. And more importantly, we need to understand this, that a patient who has been infected with like Corynebacterium diphtheriae, he has to be tested for the antitoxin sensitivity, so that like you give it, and then you get to know that, oh shit, he was already sensitive, because of which he'll get into anaphylaxis. So you need to be very careful about that. So test that on the mucocutaneous or other places. That is more important. So how do you give this is, so if it is a patient, if you give almost 20,000 to 40,000 units of antitoxin for diphtheria, which is less than 48 hours, and the membrane is only confined to tonsils. And if the patient, you give the patient 80,000 to 1,20,000 units of antitoxin for a person who has had diphtheria for greater than 48 hours, and the membrane is more extensive, right? But sometimes we also include, not sometimes, but you also usually include these antibiotics such as the penicillins, which are broad spectrum, for almost 600 mg for 6 hourly, that is almost 4 times a day. And all of this is given IV, right? The antitoxin is also given IV. That is one thing which you need to understand, that you give this IV, and it's given like 1 hour once, no, not 1 hour once though. It's given IV infusion for about 60 minutes, right? So that is what is done. But more importantly, now I have to tell you about the small summary. If you can kind of remember that, that is going to help you remember this through a trick. So Deepthi is a person who is very dirty, and she's high bleeding, and the fact that her heart and the nerves are messed up, and she has come from a trip, probably after 6 days, all of this has started, and probably it's bilateral for her. This, like this pain in the tonsils. So Deepthi is that person who is bleeding. So this will kind of give us the summary to remember faucial diphtheria in the ENT perspective. Chronic tonsillitis. Talking about chronic tonsillitis, we have to talk about the etiology of it. So when we're talking about the etiology, it's usually the acute tonsillitis which progresses to something called as chronic tonsillitis. What happens is there will be these micro abscesses which are being replaced with fibrous tissue, which ultimately populates the whole of lymphoid follicles. This is a subclinical type of infection. So that is the etiology also, like so some other subclinical infections which are there, which will lead to this chronic tonsillitis, and sometimes it might reoccur as an acute attack. And this usually happens in children, like young adults, and affects children, and rarely occurs in people who are of old age. So if you're old, don't worry, it won't happen to you. Then let's talk about chronic infections in sinuses and teeth. Like there are people who do not take good dental care, and if they are having sinuses and if they're having this chronic infections, then that can also lead to chronic tonsillitis. Talking about the types, like how it was there in acute tonsillitis, here it's chronic follicular tonsillitis, chronic parenchymatous tonsillitis, and chronic febrile tonsillitis. In chronic follicular tonsillitis, there is this yellowish bleeding, right? These yellowish spots which are there in the crypts, right? And there will be this cheesy material, that is what it is. Then we have chronic parenchymatous tonsillitis, where the hyperplasia of the lymphoid tissue is seen, and like this will interfere with the deglutition, respiration, speech, and all of that. And so badly that it becomes so big that sleep apnea syndrome can happen, and people will have sleep apnea will have, and they'll have cor pulmonale on the long standing conditions, like they'll have this right heart failure. Then you have chronic febrile tonsillitis. What happens is here the tonsils shrink in size, but they'll have repeated sore throat. So all those people who will keep on complaining in your friend group saying, "Hey, I have sore throat. I have sore throat. I won't be able to come to class." Well, that's because they're telling that. When we're talking about chronic tonsillitis, three things are very common, and they are the most clinical features which you have to kind of remember, or the features which you have to remember. One is the anterior pillar, with this anterior pillar with flushing. Second is the jugulodigastric nodes, lymph nodes which are enlarged. These are the two important things which you have to consider as an important chronic tonsillar triad sign. But along with that, the tonsil could be enlarged, or it could be small, or it could be yellowish bleeding. This is something which is variable, but these 2 points, like jugulodigastric nodes involved and anterior pillar function, you should always suspect about chronic tonsillitis, right? Clinical features, we need to understand that so the person will have recurrent infections of sore throat and acute tonsillitis, chronic irritation, and they'll keep on coughing. They'll be like, I have this cough which is always there. Then they have a bad taste. They have bad taste and foul breath, halitosis. Then we have these people will have problems in the night because they'll have choking in the night because there will be less oxygen also. Plus, there will be this obstruction. That will be the problem. So, thick voice, halitosis, cough, and recurrent sore throat. Examination. So you have to check for kissing tonsils. You have to see these tonsils which are almost meeting in the midline. This usually happens in the chronic parenchymatous type because it's the parenchyma enlarged. Then you have the yellowish bleeding which is seen on the medial surface of the tonsils, which is seen in chronic follicular type. Then talking about pus, sometimes what happens is even if the tonsil is small, if you were to press on the anterior pillar, you can see some pus, right? So this is usually seen in the specific chronic fibroid type. And of course, we spoke about the flushing of the anterior pillars, which is an important sign, and then we spoke about the jugular digastric nodes, right? Then talking about the treatment, see, the treatment here is conservative. It's not like you can do something very radically. Of course, you will do it radically if it is tonsillectomy, but it is only in specific indications where it is stopping deglutition, stopping respiration, and something like that. But conservatively, you can, manage it with general diet, treatment with, some other antibiotics for infections, or clean the sinuses or something like that. Complications, well, see, it can have peritonsillar abscess, parapharyngeal abscess in and around the pharynx. Then you have the intratonsillar abscess. Within the tonsil, the abscess can happen. Tonsillar lids are very characteristic here. The stones can happen within the chronic tonsillitis. There will be so much irritation, so much of infection that stones will happen, and even cysts will happen because of this chronic irritation. Sometimes it might disseminate to different organs such as the heart, causing rheumatic fever, or the acute glomerular nephritis. Well, they are also the etiological parts, of course, in acute tonsillitis. Talking about the tonsillar lids are calculus of the tonsils, right? They are the stones. So what happens is they block the crypts. When the crypt is blocked and by debris, right? They are debris of calcium and magnesium usually, and they form a stone. And they usually, because of obstruction and decreased oxygen and chronic irritation, there will be ulceration, right? They, because of blocking also. The tonsillar lids will cause local discomfort and foreign body sensation, and if you were to probe it, you will find that there is a gritty nature, or palpation. You will feel it. Of course, simply either remove the stone, or if it is too bad, then remove the tonsil itself, right? But it all depends upon if there is any subsess, or if there is any stone which is not even easily accessible. Talking about the intratonsillar abscess, we need to understand that this is pus within the substance of the tonsil, as the name suggests, and it usually follows blocking of the crypt. Like after the crypt is blocked, and blocking of the crypt and opening in the acute follicular tonsillitis type, and they'll have pain and dysphagia. And treatment, you have to give them antibiotics and try to, anywhere there is abscess in the body, drain it. Tonsillosis are, again, these are yellowish swellings over the tonsils which are often symptomless, and they're drained. uh, what is important to understand is that we are so myopic towards this tonsil, fascial tonsil, that we forget the lingual tonsils, which are at the base of the tongue. So what happens is, this lingual tonsil is also very important because it can have, acute lingual tonsillitis, an infection, or it could get hypertrophied, and there could be abscess. It's usually like a progression. When we're talking about acute lingual tonsillitis, very characteristically, you'll have unilateral dysphagia and you'll feel like there is a lump in the throat. There is something in the throat, right? And what happens is, this is usually studied with follicles. Well, this will also see enlarged if you were to put a laryngeal mirror, like as you see in acute follicular tonsillitis. How do you treat it? Give antibiotics, right? And this would also involve usually the lymph nodes, right, cervical group of lymph nodes. Talking about the hypertrophy, what happens is after a tonsillectomy, usually compensatory hypertrophy happens in this lingual tonsil tissues. So what happens is, there'll be discomfort and swallowing, and there'll be repeated infections. So yeah, that is the problem. Then you have this. They'll have this thick voice. They'll have the feeling of lump in the throat. Abscess in the lingual tonsil is something which is rare and also a dangerous condition because it will cause laryngeal edema, and the reason is, it can usually follow the acute lingual tonsillitis after an like a progression of a disease, right? As I told, so the symptoms are usually unilateral dysphagia, again, lump in the, you know the neck, and there will be well, here the symptoms are quite characteristic. There are a combination of four things usually.
Lump
uh,
in the throat, not neck.
Lump in the throat. So there are four things in usually. That is, they'll have some degree of trismus, they'll have unilateral dysphagia, they'll have some intensive salivation, and they will have pain in the tongue. So these four things are characteristic things, and of course here the jugulodigastric lymph nodes are again involved, as I did mention, because and that is where things become very bad, like they exacerbate, and laryngeal edema can happen, which is a dangerous condition, and people can't breathe. Choking can happen. Okay, when we're talking about the reasons or the differential diagnosis for a membrane over the tonsil, we need to consider a lot of things. First, we'll start with something called as membranous tonsillitis. Well, this is the a progression of any acute tonsillitis, basically, and this is a condition in which there will be acute tonsillitis kind of features, but along with that, there will be exudative membrane over it. Well, this is caused by usually any pyogenic bacteria, right? Then you have to talk about diphtheria. Well, diphtheria is very special because and membranous tonsillitis will definitely be, I think, will be definitely bilateral. Then you have something called as diphtheria. Diphtheria is definitely dirty. The membrane looks very dirty, and this is something which happens slowly. It does not happen acutely, but it happens.
Dirty gray.
Yeah, it is dirty gray. At the same time, it is something which happens, slowly. It happens. It's in something which happens slowly, like insidious in onset or slower in onset. Then, here the beauty thing about the membrane is that it, extends beyond the tonsil. It goes beyond the tonsil onto the soft palate, and the best part is that this bleeds. That so it is easy to, kind of find out, okay, if it is, diphtheria, because it's a bleeding this thing. So Deepthi is dirty and she's bleeding, and in this kind of patients, the urine will show albumin, right? And if you were to do a smear of the membrane, you will see corynebacteria and diphtheria. Then you have Vincent angina, which is another differential diagnosis. Well, it's a unilateral kind of condition. That is one thing you need to understand, and it's insidious in onset. Where if you were to take the membrane and do a culture, you will find spirochetes, right? And then there is, here the thing is, it can easily be removed. That is another thing, with respect to Vincent angina, that it can easily be removed, and revealing an ulcer. There will be an irregular ulcer, on the tonsil. So that is something about the Vincent angina. Then we have talked about infectious mononucleosis. So, well, it's caused by the Epstein-Barr virus. So we'll be testing it with a Paul Bernal test. But more importantly, this infectious mononucleosis, if it's presenting clinically, it shows bilateral involvement and involvement of the posterior triangle lymph nodes. At the same time, it will have, increased lymphocytes. Like there will be increased blood smear will show increased lymphocytes, in which almost 10% will be atypical, and Splenomegaly is another thing which is involved because these atypical cells would be destroyed in the spleen and spleen would increase, so there will be increased functions. So that will be infectious mononucleosis. Then you have agranulocytosis, a condition in which the unilateral or bilateral involvement is there where there is
ಯಾರೆಲ್ಲ bilateral ಅಂತ?
uh, I think it is bilateral, but okay. It presents with ulcerative necrotizing lesions. Fine. Agranulocytosis presents with ulcerative necrotizing lesions, and the cell count is decreased than 2000.
Only thing we know about lesion is it's ulcerative necrotic.
It's ulcerative necrotic. Along with that, we need to understand that the patient is severely ill. Okay, the patient is severely ill, and the acute leukocytic count is decreased to less than 2000 per cubic millimeter, sometimes even less than 50, which basically means that the person is having decreased WBCs, and so much in fact that they are not even functional. So this will have marked granulocytopenia. Then we have leukemia. Leukemia, we know it usually happens to any age. There could be any age predisposition. There are certain leukemias which are predisposed to child, so some to older people. But the total leukocyte count would always be greater than 1 lakh cubic per millimeter, and they'll have anemia because this WBC picture is going to suppress the RBC cells, progenitor cells, and they'll also be not functional. And the bone marrow examination, something which will lead us to the diagnosis, better diagnosis. Then we have aphthous ulcer, something which involves the oropharynx, which is another differential diagnosis for membrane over the tonsils. So there will be solitary, or sometimes they might involve the tonsil or the pillars. But the thing is that they're extremely large.
Sometimes we know tonsil.
Right? Okay. They could be sometimes quite large, and in fact there will be alarming. There will be that big, and it's very painful. Like aphthous is a person who lives alone and is in too much of pain, right? Then you have malignant tonsils. Sometimes any cancer to the tonsil could also be another problem. Then you have traumatic ulcers. Let's say you have had a injury to your trauma, or you have been using your toothbrush too roughly, or you have been putting a pencil into your mouth, or been fingering the throat a lot. So that causes
correct.
formation of a membrane, and the membrane appears within 24 hours, right? Then you have this candidal infections of the tonsil, which is again an ulcerative ulceromembranous lesion. Candidal infections, which are again predisposed to people with HIV and other diseases. What do you have to diagnose? How do you diagnose? What is the clinical procedure to kind of diagnose these membranes and try to come to a proper diagnosis? Is you have to take a set of things. You have to take a proper history, do some physical examination to that tonsil. Make sure you take a blood workup done to check for agranulocytosis, leukemia, or neutropenia. At the same time, do a blood smear to see for atypical cells. If the cells are of good nature, then you do something like throat swab or culture just to see if there are any bacteria. Take a membrane swab and check for bacteria. If it's spirochetes, check for Clostridium, Corynebacterium diphtheria, check for Candida. If a bone marrow aspiration is necessary, and if you think it is a leukemic picture, then take a bone marrow biopsy, or do a pulmonal test, especially for diseases such as infectious mononucleosis.